Now let's come to the clinical presentation of asthma and COPD. How do these patients present? Asthma patient. Asthma patient is usually a young patient, usually younger than 45, usually a child. And you can find history, whether personal or family, history of atopy. What's atopy? Tendency towards allergy. Usually there is a history of allergy present, whether in the patient or in family. Hay fever, allergic conjunctivitis, allergic rhinitis, some history of allergy. Who gets COPD? Old ones. At least older than 45 years. And usually these patients, you will find a lot of cigarette packs in the patient's history. Usually these patients are heavy smokers, more than 20 packs a year. What if your COPD patient was younger than 45? COPD in a 35-year-old patient? COPD in a 38-year-old patient? What should you think of? Yes, you should think of alpha-1 antitrypsin deficiency, which accounts maybe for the 1% of patients who got COPD and they were not smokers. Symptoms of asthma, as I said, dyspnea, cough, wheezes. Dyspnea, cough, wheezes. Surprisingly, wheezes are not the most important symptoms or the most common symptoms of asthma. On the other hand, dyspnea is. Shortness of breath is the most common symptom of asthma. And also you can add to this chest tightness. So cough, dyspnea, wheezes, and chest tightness. And the patient may be asymptomatic between attacks of asthma. So asthma patients have good days and bad days. If they do not have the attack of asthma, they look normal and even there will be no physical findings. COPD patients, on the other hand, cough, dyspnea, and sputum. Cough, dyspnea, and sputum, and they can show the manifestations of right-sided failure. But COPD patients, they have no good days. Their days are either bad days or worse days. They are always symptomatic. And they can have attacks of exacerbation. Physical exam. In asthma patients, the physical exam is usually normal unless they have an attack of asthma. In COPD patients, we have a lot. Again, wheezes is not a constant finding in COPD patients. We only see wheezes when they have exacerbation. The most common auscultatory finding in COPD patient is not wheezes, it is decreased breath sounds. Why? Because the pipes are closed, the bronchi are obstructed, the air moves in and out with great difficulty, so you get decreased breath sounds. Why is the hyperresonance? Remember when I said when in COPD you destroy the lung parenchyma, you turn the alveoli, you destroy the alveolar septa, and you turn the tiny alveoli into one big balloon, and it's always easier to inflate the big balloon. You inflate your chest and you cannot get air out because of airway obstruction. You trap air inside your chest, and this leads to hyperresonance. When you examine the chest by percussion, it's going to resonate. There will be hypoxemia, cyanosis, and clubbing, and the barrel-shaped chest, the increased anteroposterior diameter. Why is that? Now we have two elastic structures here. The thoracic cage is an elastic structure, and the lungs is another elastic structure. Any elastic structure has a natural tendency. The elastic recoil of the thoracic cage always tends to get the chest bigger. So if you free your thoracic cage from the lungs, your thoracic cage is going to follow its natural tendency and will get bigger and bigger and bigger. On the other hand, if you took your lungs out, their natural tendency will be to collapse. So now your chest always wants to get bigger and your lungs always want to get collapsed. So they are moving kind of this way. In COPD, the lungs will lose their elasticity. So the chest cavity or the thoracic cage is going to get bigger, follow its natural tendency, and it will not be opposed by the natural elastic recoil of the lung. So it's going to expand and it's going to force the lung to follow, and you will acquire this barrel-shaped chest. Pursed lip breathing. These patients teach themselves to breathe this way because this improves their ventilation, moving air in and out. And because of this air trapping, we get subxified point of maximal impulse, because the whole heart elongates and the point of maximal impulse is deviated downward. Pulmonary function testing. This is a big deal in the diagnosis of asthma and COPD. Now, as I said, asthma patients have good days and bad days. On their bad days, they are typical obstructive airway disease like COPD patient. How to diagnose any obstructive airway disease? You have to have low FEV1 to FVC ratio less than 70%. What's FEV1? Forced expiratory volume in 1 second, in the first second. What's FVC? Forced vital capacity. In any obstructive lung disease, the ratio of the patient's FEV1 to the patient's FVC is always less than 70. So to diagnose obstructive lung disease, you have to have this pulmonary function test done. Pulmonary function test, you have to refer the patient to a spirometry unit and they do the test, and the ratio is less than 70 in both of them. Both of them will have low FEV1. Asthma on their bad days will have low FEV1. But the difference here is, asthma patients, you give them albuterol, 4 puffs of albuterol, their FEV1 will improve significantly. And by significantly, when I translate it to numbers, more than 12% improvement. COPD patients, when you give them albuterol inhaler, their FEV1 is going to improve also, but just a little bit, less than 12%. This is a key feature in diagnosing asthma and COPD. FEV1 is the test, is the pulmonary function test that correlates with airway obstruction. The more airway obstruction, the less your FEV1. The more airway obstruction, the less your FEV1. But FEV1 is a pulmonary function test. You cannot do pulmonary function test at your office. You cannot do it even in the ER. And of course, the patient cannot do it at home. What is an easier test that correlates well with the FEV1 and is a more handy test? This is the peak flow, the peak expiratory flow that I'm going to show you later. So the peak expiratory flow is the handy, easy test that correlates well to the FEV1, and both of them will reflect the degree, the severity of airway obstruction in obstructive lung disease. So asthma patients will present as shortness of breath with expiratory wheezing, and there is a very common saying is, not all that wheezes is asthma and not all asthmatics wheeze. Wheeze is not the key feature in asthma, and I'm going to have another slide to show you the different causes of wheezing. In severe cases, the asthma patients may use their accessory muscles and cannot complete even sentences. What are the most important features of severe asthma exacerbation? Hyperventilation with increased respiratory rate, decrease in peak expiratory flow, which corresponds to FEV1, hypoxia. Respiratory acidosis is a very bad sign in asthma exacerbation. When the asthma symptoms worsen, the patient will breathe fast. When you breathe fast, what do you expect your carbon dioxide to be? You expect your carbon dioxide to be low. What do you expect your pH to be? Your pH is going to be high. You're going to have respiratory alkalosis. That's natural because you're breathing fast. You're washing out carbon dioxide. But if you have respiratory acidosis, despite the fact that you are breathing fast, this means you are in a very bad condition, because this fast breathing is not helping to get rid of carbon dioxide, and your carbon dioxide is accumulating, and that's why you have respiratory acidosis. Respiratory acidosis in a patient with asthma exacerbation, respiratory acidosis in a tachypnea patient is a very bad sign, and this necessitates admission to the ICU and maybe even ventilation. Sometimes in asthma exacerbation, you do not hear wheezes at all, and this means not you are free, but it means that your airways are so blocked, so much constricted that there is no air moving in and out, and therefore you cannot hear any wheezing. For COPD patients, usually you're going to find a long-term smoker with increasing shortness of breath and decreased exercise tolerance. Usually this is how they present. They present to you because they get tired easily. They cannot tolerate exercise, and they have progressive shortness of breath. Shortness of breath, as I said, is the most common symptom in both asthma and COPD. Here is the differential diagnosis of wheezing. You can have wheezing due to extrathoracic causes. Anaphylaxis will result in wheezing. Vocal cord pathology will result in wheezing. Laryngeal stenosis, goiter. Or you can have wheezing due to a problem in the upper airway, like tracheal stenosis or mucus plug. Or more commonly, you can have wheezing due to lower airway problem other than COPD or asthma. Heart failure is a common cause of wheezing, and foreign body aspiration is another common cause of wheezing. So what I want to say is wheezing can happen not due to asthma.